As the final meals are being served, I'd like to introduce Dr. Michael Anderson, who's going to be introducing our featured speaker today. Mike is not only a John Carroll graduate, but he is a tuition-paying father to Walsh Jesuit and St. Ignatius. And we... And it's also a good thing we don't publish titles of the panel here in the program, because just last week, Mike was promoted to Chief Medical Officer of the entire UH system. So congratulations, Mike, and thank you for being with us today.
Good afternoon. I was told that by doing the introduction, I got 10% off tuition, so I'm not sure if that's not true. Oh, darn, I thought that was true. You know, 2014 is a special year for all of us. I'm not sure how many of you remember from your Jesuit education, but in 1814, some 200 years ago, Pope Pius VII ended the 41-year-long suppression of the Society of Jesus. Because he restored the SJ, all of us have had the opportunity to acquire the Jesuit education that helped to make us who we are today. Today's guest speaker, my boss, Tom Zenty, is one of us. He studied at a fine Jesuit institution and is truly a man for others in the Jesuit tradition. Mr. Zenty has served as Chief Executive Officer of University Hospitals for the past decade. In those 10 years, he has built on UH's solid, nearly 150-year-old foundation to transform our system into truly a national leader. Mr. Zenty implemented a financial turnaround that put UH in a strong position for the future. He oversaw a $1.2 billion strategic expansion of our system called Vision 2010. It added the UH Seidman Cancer Center, UH Ahuja Medical Center, and many other projects, including our new newborn intensive care unit. Mr. Zenty also used Vision 2010 to break new social justice and economic empowerment ground by including female and minority-owned businesses at levels never before seen in this region. That leadership changed the way business is done in Greater Cleveland today, and I hope he'll speak to that. Under his guidance, UH Case Medical Center won the prestigious American Hospital Association McKesson Quest for Quality Prize in 2012. And today, our flagship medical center is one of only 18 hospitals in the nation, 18 hospitals in the nation, on the elite U.S. News and World Report Best Hospitals honor roll. Some important highlights from Tom's career. Tom earned his Bachelor's of Science in Health Planning and Administration from Penn State University, a Master's of Public Administration from NYU, a Master of Health Administration from Xavier University, his Jesuit tie, and has completed Harvard University Business School Executive Education programs. As far as service, Tom is active on the boards of many community-based organizations and national professional associations. He served on the boards of publicly traded and private corporations. He has chaired the Coalition to Protect America's Health and is past trustee of the American Hospital Association. Modern Healthcare has listed Tom among the 100 most influential people in healthcare. He is on the Northeast Ohio Business Hall of Fame and is perennially among Inside Business Magazine's Power 100 leaders in Northeast Ohio. Mr. Zenty serves or has served on the faculty of colleges and universities in the U.S. and internationally. Under Tom's leadership, UH has grown market share, augmented clinical research, and expanded community benefit contributions substantially. UH is home to the Harrington Discovery Institute, an innovative initiative supporting leading physician scientists from across the nation in the development of and commercialization of new drug therapies. And more than 65,000 individuals or institutions across our region have endorsed Mr. Zenty's vision for our healthcare system, with more than $1.1 billion in financial support. Please welcome our guest speaker, Mr. Tom Zenty.
You're way too serious. Well, good afternoon. Can you hear me okay with the mic? Is it working? Great. It's nice to be here. I preferred to actually sit on a chair as opposed to use the podium because I'm hoping, frankly, that this will end up being more conversational than a soliloquy. So I prefer not to use the podium, and we'll leave plenty of time for questions and answers. And Mike, thank you for that great introduction. For those of you who don't know Mike, he's had a very illustrious career at university hospitals and is one of clearly our stars. The problem, Mike, is unfortunately today you're going 0 for 2, and the reason why I say that is because not only do you not get a 10% decrease in tuition, you don't get a 10% increase because of your promotion. So, hate to break it in front of 275 of your closest friends, but it's the best I could do. I actually rode with Mike. So I'm sure that you're all here today because we really have a lot of changes happening in our healthcare world, and there are very few of us who will not be affected at some level by what's happening in healthcare today and tomorrow. So my remarks today, I'm going to calibrate to about a 25-minute presentation because I think it's important for there to be plenty of time for Q&A, but I wanted to talk about values-driven leadership. And having said that, there are a number of university hospital employees here who actually do all the work of the day and allow us to accomplish our mission, and I'm wondering if you would please stand up just so we can recognize all the UH people who are here. I saw some people walking in this side. Mike, thank you. And they're here both to keep me honest and participate in the Q&A session as well. So I want to break up talk about, but time limits us really only to one. And a colleague of mine said not too long ago that there is a significant difference between the business that we're in and the work that we do in healthcare. So today I'm going to be talking about the business that we're in because this is clearly something that has garnered the attention of everyone in Washington, in Columbus, and certainly in the United States in general. As I go through my remarks, I'd like you to frame your thoughts, though, around our values, and that's what I mean by values-driven leadership. And our values are excellence, diversity, integrity, compassion, and teamwork. And these are the 5 tenets that really drive who we are and what we do and create our corporate culture. So in that category as well, I think you should also think about what we're seeing happening as a result of some of the changes in healthcare. For example, think about this particular moral hazard. It's been shown in study after study that a $5 copay will prevent patients from seeing their physicians. A $5 copay will prevent people from seeing their physicians or seeking needed medical care. Secondly, I'd like you to think about the role of the individual. And whether or not you believe in Ptolemy or Copernicus, I think at the end of the day, we're really challenging even Copernican theory because hospitals, which have been, are really no longer going to be in the future the center of the healthcare universe. There's no doubt that we're the largest component of spending, and I'll talk about that in just a moment. But begin to think about what your role is in your own health and focusing on prevention and wellness as opposed to only the type of intervention that we and you will be receiving. Also think about what's your ideal. What do you think about healthcare? What's the best for you in terms of healthcare? What would you expect in a healthcare delivery system? And then, of course, what are the moral imperatives that we all share? My intention today is to inform and not instruct. I'm just going to hopefully introduce some topics and some thoughts that you might not have thought about. And most importantly, I'm agnostic to party and person. So when I talk about healthcare reform, I'm going to refer to the Patient Protection and Affordable Care Act, the PPACA, and not Obamacare. So this is not going to be personalized, at least during the course of my presentation, although it's taken on the popular moniker. And I'll also mention that to date there have been 43 efforts to overturn the PPACA, to date, none of which have been successful. We're going through historic and transformational change in our industry, and I'll talk about that in some of the details that I talk about, but I'm also convinced that the Patient Protection and Affordable Care Act, quite frankly, was really only a catalyst. Because I'm convinced, and maybe you will be too by the end of my presentation, that healthcare reform was going to be occurring whether there was a federal mandate or not. So as I go through my remarks, I also want you as well to think about that if we do this right, we really can create a better, more coordinated, more efficient healthcare delivery system than we have today. We can be more cost effective, and we can allow people to lead healthier and internationally, because the cost of medical benefits now for corporations in the United States is at historically high levels. If you look around the world, the United States spends about twice what all the other OECD countries spend on healthcare. Probably Switzerland is behind us, Germany is behind us, they're the next highest, but we spend about 2x what's spent around the rest of the world in healthcare delivery. And there are a number of reasons for that, but I'll come to that in just a moment. And if we think about how much we spend on healthcare in the United States today, the bill for healthcare in the United States is now about $2.7 trillion a year. So if I'm going to be speaking to you for about 25 minutes, that's about $100 million a minute. So hopefully my remarks will hit the point. Because this is very, very expensive. I'm convinced we live in one of the best healthcare countries in the world, but with lots of room for improvement. And then likewise, if you think about healthcare today, if healthcare were a country, we would have the 5th largest GDP of any country in the world. So very large, very complex with a lot of moving parts. So in spite of the fact that we spend so much money, though, we don't have the best healthcare outcomes in the world. In fact, by many measures, we lag behind even developing, not just developed countries. We have a shorter life expectancy than most other peer nations, and we have the highest infant mortality rate and rate of low birth weight babies among high-income and low-income countries around the world. Because of healthcare costs, about 37% of U.S. adults went without recommended care. That number, contraindicated in Sweden, is about 4 to 6%. And about 23% of U.S. adults had serious problems paying for their medical bills or couldn't pay. That number is about 6% in the United Kingdom and in Norway. And healthcare is the #1 contributor to personal bankruptcy in the United States, either because people can't afford to get the care or because of lost work of their inability to get care. So there are a lot of things that we need to think about as we look for solutions, but we can't ignore, I think, the social imperatives that I've just outlined for you as well. But there are a number of factors why we spend so much money on healthcare in the United States. Number one, salaries and wages for virtually everyone in healthcare is about twice what you would find anywhere else in the rest of the world for people who are involved in the healthcare world. The cost of medications and other pharmaceuticals in the United States is the highest in the world by virtually every measure. We have a very high regulatory burden. We have a relatively high administrative burden as well, because as you know, we have by many measures a for-profit approach to the way in which insurance is provided in the private sector. And Medicare and Medicaid make up about 50% of the bill for hospitals in the United States. We also have to think diligently about how we care for our elderly. So if I were to show you a graph of the top maybe 4 or 5 OECD countries in the world, you would see that our level of spending is about equal between the ages of 0 and 60 to 61. But in the United States, beginning at the age of 62, the curve shifts almost like a hockey stick. And the amount of money that we're spending on people in that age bracket over the age of about 62 is much higher than it is in the rest of the world. And I'm not saying that with any prejudice, and I'm not saying that with any value judgment. But the facts are we spend far more on certain segments of our society than we do in other developed countries. We also have fewer social structures that people can depend on to seek non-medical care services. And many times, even though we are not part of the problem, hospitals are the only solution. And what I mean by that is, for example, at 2 o'clock on a Saturday morning, when there is a patient who is clearly having a problem that would be perhaps psychiatrically based, there are no community services any longer, or very limited ones, that the police or first responders can actually use. So what do? They come to a hospital emergency department because it's the only place that's open 24 hours a day, 7 days a week. How we address poor prognosis and end-of-life care is something that we must think about. It's a key component of our spending, and it's something that when I tell you, you may be surprised, but perhaps not. But unless we really address this issue, I think we're going to be short-sighted in terms of how we're going to be able to deal with rising healthcare costs. Again, not value-laden, but just statistically speaking, 5 to 6% of all Medicare patients die each year. About 25% of all Medicare dollars are spent in the last year of that person's life, and about 60 to 70% is spent in the last 3 to 4 months of that person's life. So how we treat poor prognosis and end-of-life care is so critically important. And again, I'm not making a value judgment here, but when the conversation 4 years ago centered around the opportunity for primary care physicians to be able to be accessed and receive payment for services that they would provide, consultative services to patients with poor prognosis or end-of-life care. Does anybody remember what that turned into? Death panels. We had a wonderful opportunity there, in my opinion, to make a significant impact on making conscious choices about how we live and how we die. But we totally missed the opportunity at that point. And then I guess the other point that I would raise is why now and why are we going through? At the end of the day, when we look at the statistics today, demographically, we have for the next 20 years about 10,000 people a day on average who are going to become Medicare eligible. And when you begin to take a look at the cost burden under the Medicare program, it would be impossible for us to sustain the kind of levels of increase that the Medicare program and the Medicaid program and others have been experienced over the past many years. So just a little bit about my personal background. I was asked to give just a brief background about who I am and where I come from. I grew up in northeastern Pennsylvania, northeast of Scranton, and went through Catholic education at the grade school level and half of high school. I graduated from the local school, the public high school in the hometown where I grew up, which was about 500 people, so it's a relatively modest-sized community. Then went on to Penn State, as Mike mentioned in his remarks. But I knew at the age of 15 what I wanted to do for a living, and that was I wanted to be a hospital administrator. So picture this, 6 feet 6 inches tall, 164 clothed, horn-rimmed glasses, gapped front teeth, and a buzz-cut haircut. I was really quite the sight, I would imagine, showing up in hospital administrators' offices, learning what they did for a living. And they were terrific mentors. They were very warm, they were very accepting, and they were very helpful to me in so many ways. I then went on to work. My very first job was an undergraduate residency in hospital administration. And I worked at a Catholic hospital there for a woman by the name of Sister Cephas Ryan, who herself was a Xavier grad, who was a significant mentor to me. And she really helped me to move my career along. When I went to undergraduate school, there were only 2 programs in the United States that had degrees in hospital administration at the undergraduate level. One was Cornell, and the other was Penn State. Cornell, their program was in the School of Hotel Management. I really didn't want to learn how to run a hotel, but I did want to learn how to run a hospital, which is why I ended up going to Penn State. Then on to Xavier, and then on to NYU, and then I began my career in Connecticut, then New York, New Jersey, Arizona, California, and now here in Cleveland, Ohio, which I think it's important to say I personally think that this is one of the best healthcare cities in the world in which we live today. I don't take a moment of it for granted. I hope that you don't either, because I've lived all across the country, and I think Cleveland, Ohio provides some of the best healthcare that we would find anywhere in the world, and it's an honor to be here. As well, when I was at NYU, my faculty advisor was a Jesuit priest, which was an interesting model, and quite a guy, and very instrumental in helping me formulate my career in the way that my career developed over time. So let me talk a little bit about the history of healthcare in the United States, because I think setting the history will give you perspective on not only where we are today, but more importantly, where we need to go. So in the early days of healthcare delivery, the first hospital in the United States was University of Pennsylvania, formed back in the 18th century, late 18th century. And hospitals have been growing. After World War II, that hospitals really took on a life of their own and really became the center of the healthcare universe. A number of reasons for that: the discovery of penicillin and other antibiotics. There were surgical techniques that were discovered as a result of the injuries in World War II. Returning soldiers had a lot of issues that had to be dealt with as well that were chronic in nature. And hospitals then got a major boost when in 1946 there was a piece of legislation called the Hill-Burton Act, or the Hospital Survey and Construction Act. And that funding was available pretty much through the 1970s. And as a result, hospitals grew up all around the country, which is one of the reasons why we have such a hospital-dominated healthcare delivery system. But imperceptibly so, over the years, spending on hospitals has actually gone down. So in 1980, we spent about 42 cents out of every dollar that we spent on healthcare on hospitals. And in 2010, the number in which the most current numbers are available, we're actually spending about 32 cents out of every dollar. So we've seen about a 25% decrease over the years in how much we're spending on hospitals today. And I think that that number will continue to decrease as we see other elements of the healthcare system growing and developing over time. The rise of sectarian healthcare was kind of interesting. Most hospitals in the United States are what are called not-for-profit. About 85% of hospitals are not-for-profit. And we're not-for-profit principally because we're considered to be charitable organizations. For those of you who are accountants and attorneys in the audience, we are generally known as 501c3 organizations, and we're tax exempt because we are a charitable organization. And sectarian healthcare was popping up all across the country because Catholic hospitals were not taking physicians who were not Catholic on their medical staffs. Protestant hospitals were not taking physicians who were not Protestant on their hospitals, and so on and so forth. So the rise of sectarian healthcare really was created principally around religion and particular types of religion. And that's why you see across the country so many hospitals. As we're seeing the demise of freestanding hospitals and the growth of systems, we're really seeing now hospitals losing some of their identities as individuals and becoming part of larger organizations. So there are about 5,400 hospitals in the United States. About half are in health systems, and the other half, of course, then de facto are individual freestanding hospitals. The estimates are that in the next 3 years, about 50% of that 50% will become part of systems, and we're seeing that writ large here in Northeast Ohio, but we're also seeing that same thing happening across the country. There are about 820,000 physicians in practice across the country. You may not realize this, but the vast number of physicians who are in practice are in private practice and are in groups of 1 or 2. And most recently, a survey was performed of graduating medical students, and they said, what is the number one thing that you are going to be looking for in a career in medicine? And they said lifestyle, followed by finances. If you asked that question 20 years ago, those answers would have been inverted. And so we're seeing major changes in the way that doctors now are interested in practicing, and hospitals in the United States today actually employ about 200,000 of those roughly 820,000 doctors. And when asked, physicians in practice currently, when asked the question, where do you see your practice going in the next 3 to 5 years, over half said they want to become employed by hospitals or health systems. So we're seeing a major change in that demographic group as well. The insurance markets, dramatic change too, as you know, under the PPACA. The idea of health insurance reform has really been in place over the past 3 years, and I think that that's going to continue to grow and develop over time. And the demographics of the U.S. population, you may or may not know this, but hospitals receive about 35% of our funding from Medicare and about 15 to 17% from Medicaid. So de facto, about half of what we get paid for taking care of patients comes in the form of federal or state government support. So that's why what happens in Columbus and what happens in Washington is so critically important to us, because so many patients are dependent on either the Medicare or the Medicaid program. Of consumerism. Think about this for just a moment as a paradigm shift. How many physicians are there in the audience? Can I see a show of hands? Okay. So think about this paradigm. Doctor, the patient will see you now. Right? Think about this. We are now doing group visits of 8 to 10 people who have like chronic conditions. And I think we're going to see more and more of this taking place. And frankly, I think that's good for our industry in the sense that, not seeing 8 to 10 patients at a time, but the idea of consumerism I think is critically important, because it's forcing us as healthcare providers to be more transparent around quality, transparent around price, and transparency around access. Because if you think about it, in our world, there was something that I studied back when I was in graduate school called Romer's Law. And Romer's Law was a bed built is a bed filled. So since 1946, we have had supply-induced demand. And now we're seeing a dramatic change. And now we're moving into the field of demand-induced supply. So for example, has been operational. We've seen in November, we've seen the lowest number of admissions nationally to hospitals than we've seen in the 50 years in which statistics have been kept. The lowest number of hospital admissions in November than any other year in which statistics have been kept. So I think that's critically important, and frankly, I think it's forcing people to think about, now that they're paying more for services, because in the United States now, about 8 out of 10 employers offer a high deductible plan. So think about that moral hazard that I referenced in the opening part of my remarks. We're moving from, and I'm trying to be mindful of the time, but we're moving from what I'll call first curve to second curve economics in the provision and the delivery of healthcare. In the first curve, it's defined by what we know and what we have known. Fee-for-service medicine, meaning what we do, we get paid for. Secondly, high quality has not been rewarded in the past. So we would get paid for services that we provided, whether they were of exceedingly high quality or exceedingly low quality as an industry. There was no real shared financial risk. Again, a focus on inpatient hospital acute care. Information technology investments were not really offices all across the country, virtually all different. Standalone health systems or hospitals were able to thrive and survive in the old environment. That's rapidly changing. And we were prevented by many measures from doing a lot of hospital-physician collaboration, because you probably may not realize this for those in the audience today. But quite frankly, we are as exposed to antitrust and restraint of trade issues as any for-profit or publicly traded organization. So we've had a lot of barriers to working with the physician community, but those are beginning to be broken down. The second curve, where we're going, and we're actually a good portion of the way there today, payment rewards population, and quality and efficiency are terrifically rewarded. So I'm going to give you an example of how we're measuring that. But the idea is we're moving away from episodic interventional care at the time of injury or illness, and really moving into population health management, which is what we think really needs to be done, so that there won't be silos of care delivered, but there will be a continuum of care delivered. Secondly, quality now for the first time in my history, and those of us in the room who work at UH or anywhere in the country in healthcare, quality for the first time is being rewarded, and lack of quality is being penalized financially. So for example, if we have high rates of readmission, we're going to see reduced payments coming to us under the Medicare program and some other of the major insurance companies. From my perspective, that's a good thing, because if you believe in the old management dictum that what gets measured gets managed, we're measuring the right things now. Thirdly, we're moving now into partnership relationships where we are sharing financial risk. And what's happening, interestingly, how many people represent the insurance industry in the audience today? Okay. What's happening is providers are beginning to masquerade as insurers, and insurers are beginning to masquerade as providers. Now, we don't know anything. Have been financiers for many years, but are moving, I think you would agree, into the realm of providing care now in ways that they haven't done before. So you're seeing insurance companies buying large physician groups, Monarch out in Southern California, for example, huge physician acquisition. And they're going to be moving now into the provider realm. Now, places like Kaiser and Group Health of Puget Sound and a place in Pennsylvania, Geisinger, have been in this business for really quite some time. But if you think about it, the medical loss ratio of an insurance company, the amount of money that they spend for their insureds to get care, is the mission statement of hospitals and providers. So there's an inherent conflict in being both provider and insurer and provider. But I think we'll find ways to work that out. We're seeing increased patient severity. To get admitted to a hospital today, you're generally pretty sick. It used to be that you would come in, spend a day, get tests done, maybe have a procedure done, stay for a day or two, and then be discharged, generally to home. Today, the length of stay in a hospital is far shorter than it's been, but we're seeing sicker and sicker patients who are being admitted to organizations. And frankly, we're seeing financial penalties if we do admit people that should not have been, on retrospective review, by the way, by non-physician reviewers, whether those patients should have been admitted at all. That's a separate topic. We'll come back and talk about that later. Scale increases in importance. It's really hard today to be a freestanding, singular hospital. And the reason for that is because supply chain, logistics, malpractice insurance, other administrative costs are going up at unsustainable rates. And by being part of a broader network, you can share those costs over a much broader base. So I'm not here to talk specifically about UH today, but if you look across the country, we're seeing lots of new entrants into the market. Private equity, venture capital are now moving into our area and across the nation in ways that have not been seen before. So what does it mean? And what are the new normals? And I'll sort of wrap up with this. There are a number of things that are happening in our world now. So for employers, as I mentioned, more and more employers are moving to high deductible plans. So in our particular case, we moved to a high deductible plan for our employee group about 3 years ago. And there's a moral imperative there as well, because what we heard when we rolled out our high deductible plan in our particular organization, system-wide, people were very concerned because we were providing health savings accounts for them, but putting in X number of dollars per month. And what they were saying was they could not get care because the HSA contributions were not large enough to cover their copay and deductible. So now what we've decided to do is we front load for our employees a full HSA amount January 1 of the calendar year in which benefits start, or when they begin employment. Negative, because people will leave us, and when they leave, they keep the HSA funding. And so we have to think through those kinds of things. But now virtually all employers, 80% of employers across the country are offering high deductible plans. Employer mandates are going to become more paramount than they've been before, but I also think that employers will have more options than they've ever had before. For providers, as I said, I think we're beginning to really rethink the idea of hospital as center of the healthcare universe. We're seeing a structural realignment in the way that hospitals operate, models of care becoming more efficient using Lean and Six Sigma that manufacturing companies have been using for years to drive out waste. Looking for ways where we're going to have a commonality of purpose and a commonality of ways in which we take care of our patients. The doctors in the audience, I think, would agree with me that the implementation of pathways and guidelines have been anathema to many physicians because science and art really intermingle at the intersection of where physicians take care of their patients. But today, the use of information technology and the use of pathways and guidelines, so during each point along the way of their stay. So when we take a look at market consolidation, we're seeing more and more of that happening across the country. We are going to be expected to do more with less. As providers, we're seeing a diminution and a degradation in how much we're being paid for services. And I'll just tell you, in our particular instance, in the past 3 years, imperceptible to most, we've taken about $60 million in expenses per year out of our operating expenses across our system. Now, when we have 25,000 employees, what can we do? We can re-educate, we can realign. Now, people may need to look to take another role within a different organization, but we have lots of opportunities for people to stay within our system so that they're going to have a terrific career advancement opportunity when they come to work within any system, but certainly within our system. Pay for performance I talked a little bit about, but let me come to, I need to wrap up here, but let me come to something that you may find to be of interest. So every month, my principal responsibility, of course, is like any other leader of an organization, responsible for planning, organizing, directing, controlling, motivating, strategic planning, everything that you would do in any other business enterprise. But we look at, as you would imagine, very traditional financial results, right? So we look at monthly financial statements, balance sheets, and so on and so forth. And what do we look at? We look at how many admissions, we look at the number of patients we've taken care of, we look at how many people are in our home care department, we analyze our revenue sources, we analyze where we're seeing growth, where we're seeing declines, and on and on and on. But let me just read for you something that Mike is very familiar with, and this is something that we started because we put together an accountable care organization. And an accountable care organization is a way of doing what I talked about earlier as we're moving from first generation to second generation healthcare. And that is under an ACO model, under an accountable care organization model, which is part of the PPACA, we're focused on keeping people well because we have responsibility for longitudinal care for them and for their families. So, for example, in pediatrics, we have 3 ACOs. We have one for pediatrics, one for adults, and one under the Medicare program for people over. So we have ACO, we probably have the broadest ACO coverage of any health system in the country, or among them, I should say. In our pediatrics department, we put together an accountable care organization that was originally going to have 68,000 children in it. It now has 77,000 because this has been growing over time. So let me share with you the kind of statistics that we're reviewing under our ACO. So remember, when I talked about what do we look at from a financial statement in terms of our performance every month, number of admissions, number of discharges, number of births, number of patients who we see on an outpatient basis, growth and development, and so on and so forth. This is what we look at under our Rainbow Accountable Care Organization. Emergency department avoidance. Think about that for a second. It sounds antithetical, doesn't it? But our goal is to keep people out of emergency departments. Secondly, complex chronic conditions. How are we managing complex chronic care? And we need to make sure that we have the right people in the right systems to manage those chronic diseases. Integrated behavioral health services. So no longer intervening at the time of an acute episode, but keeping people well, doing things that we need to do to make sure that behaviors are being monitored, that behaviors are being taken care of, and not just at the time when there's a problem. Checkup for quality. How are we monitoring the quality of care that we provide? Now, we do that anyway, but this is all part of this entire portfolio. What are we doing in terms of outreach, and how are we managing population health? So when we think about our world, this is living proof of the fact that what we're looking at today under this ACO model is clearly changing the paradigm from where we were as recently as 3 or 4 years ago. So let me talk a little bit then in conclusion. I won't cover everything I hope to, but let me just talk for a few minutes about values-driven leadership. Because when Mike introduced me, you may recall that there are some things that we are particularly and vitally interested in, and that is the health of the people who we take care of. So into the area of excellence, Mike referenced the fact that there are now only 5 cities in the country that have 2 hospitals on the U.S. News & World Report honor roll. Cleveland is now the 5th city. Until now, there were 4. And University Hospitals made that list for the first time. Secondly, under the area of excellence, we also have won a number of Beacon Awards for the nurses and nursing care that we provide across our units, especially at Case Medical Center. And we've been #1 for 7 years in a row in equity of care, meaning whether you are white, black, Asian, Asian American, female or male, the care that's provided across our system is even and equal. And we're the #1 hospital in the country as measured by University Health System Consortium. In the area of diversity, we did a lot in the area of supplier diversity. If there's a question, I'll be happy to talk about that. But we're doing a lot in terms of mentorship, growth, development, physician recruitment. And we're doing a lot that has recognized validation from third parties like Diversity Inc. We're the #1 health system in the country now for diversity. We still have a long way to go. So by no means is this a laurel that we're resting on. Integrity, we were identified, Cheryl Wallace here, she's our Chief Compliance Officer. In 2012, we were identified as one of the world's most ethical companies. In compassion, I have a number of patient letters. I won't have time to read them today. I thought if I had time, I would be happy to do that, but I won't have time today. Teamwork, critically important to make sure that we are all working together, pulling in the same direction to do everything that we can to meet our mission, which is to heal, to teach, and to discover. And so, in closing, I would say it's never good to use a war analogy, but one of the comments that I like the most came from Winston Churchill after the Second Battle of El Alamein. And in addressing the British people, he said, after this victory, which they sorely needed in Africa because they had not been having much success in times prior to that, he said, this victory is not the end, it's not the beginning of the end, it's the end of the beginning. And if you think about it, we are really at the beginning point now of doing things that we have never done before in our healthcare delivery system. And I think it will lead to better outcomes at lower cost with more than just interventional, episodic occasions of service. But what we need to do as an industry is to make sure that we're going to be taking care of all of your and our total healthcare needs. So with that, I'll stop and turn it back, and happy to answer questions if there are some.
Insightful remarks, and with that, we'll go right to questions. We have a few minutes for that. And sir, if you'd like to lead off.
So, a question regarding hospital consolidation, which you talked about. What's the end game for hospital consolidation? Does that imply perhaps that UH becomes part of something larger as the process continues to evolve?
Yeah, the consolidation world across the country reached its zenith actually about a year ago. But I think, again, it's only the beginning. So what is the end game? Nationally, there are some estimates, and I don't think it's true personally, but the estimates are that we may have as many as 10 health systems across the country taking care of the healthcare needs of 330 million people. That may happen at some point, but I think that's really a bit of a stretch. What we're seeing happen in our market is the freestanding hospitals are now virtually all fully aligned. There are really put together requests for proposals to become part of larger systems. And you mentioned what's happening in our particular marketplace. And I think you're right about Parma and Elyria. And we just signed a letter of intent to take a look at perhaps having Robinson join us as well. But they're doing it for the right reasons. And the reasons are those that I stated before, among others. So we will see more systems growing. We will see more interstate systems that are going to be developing as well. But we're also going to be seeing organizations changing. So for example, if you had an interest in this, I'll just mention it briefly, but take a look at what happened at what's now called Dignity Health. Dignity Health used to be known as Catholic Healthcare West. They changed their name because they didn't want to be Catholic. They didn't want to just be healthcare, and they didn't want to just be West. So they changed their name to Dignity Health. And they have designs of being a multi-state organization now. If you look at what's been going on with a number of the other sectarian systems, they're looking at becoming more than what they have been in terms of size, scale, and scope. If you look, I believe, few freestanding Jewish hospitals remaining in North America today. In fact, I think there are only 3, when there were far more Jewish hospitals that existed before. But through assimilation, organizations are beginning to lose their history and they're beginning to lose some of their traditions. So for example, we have a partnership relationship with the Sisters of Charity of St. Augustine. And in so doing, in that relationship, if you were to drive by St. John Medical Center, you will see it says St. John Medical Center, a Catholic hospital. We're not going to lose that identity because it was important to the sponsoring congregations, and it's important to us as well. So I don't think there are going to be 10 systems. I think that there will be fewer systems than we see today. Catholic Healthcare East and Trinity just agreed that they were going to be coming together, but then they agreed that they are going to be examining what the strategic value is. Henry Ford in Detroit, closer to home, was coming together with a system there, but that ended up coming apart after about 6 months of due diligence. So I think we're going to see some growing pains, but it's really, really difficult today, if you're a single freestanding hospital, to be able to invest in information technology, computerization, electronic health records, buy supplies at rates that are lower than you can get if you were higher rather than if you were not part of a system. Engaging employees in ways that are difficult to do because you're a single freestanding organization. So I think we're going to see a lot of attempted mergers. I think we're going to see some failed mergers, and we're seeing it now. But I think at the end of the day, the equilibrium will be such that more and more hospitals will become part of systems in the main across the entire country.
Any other questions? Yes, sir, in the back.
How about consolidation of positions and the fate of independent positions?
Yeah, you know, physicians by their nature had been trained and educated to be independent thinkers, right? And that's what you're looking for in a physician. If you look at how physicians are trained today, medical school curricula are around team learning. So I think we're seeing a change in the way that physicians have an interest in practicing. I referenced my comment earlier in that about 3/4 of the graduating medical students, when asked what profession do you want to choose, 3/4 said lifestyle. They weren't specific about what it was, but what does that mean? Well, it means where you have predictable hours, where you have a predictable patient load. It's probably not going to be in the area of primary care. 12% of doctors today are in primary care. But if you're a family practitioner or an internist, you need to be on call 24 hours a day, 7 days a week. And by the way, you're at the lowest end of the payment scale of virtually all physician groups. Don't take this the wrong way. If you're a dermatologist, I can't, maybe the doctors can think of one, I can't think of a dermatological emergency, right? So your hours are very predictable. And guess what? You work Monday to Friday, predictable patient flow. And I think what we're seeing now is physicians who had been independent in the past, many are fiercely independent, and we admire that. And we work with a lot of independent doctors. But more and more doctors want to become employed and become part of systems. And as I said, about 20% of all doctors now are employed by hospitals, and more want to be employed. So I'll sort of leave it at that.
Let me just throw one in myself, because I have a question. In light of healthcare reform and the need for new primary care doctors and the limited number of physician assistants and nurse practitioners, how is the need for primary care doctors going to be met in medical education? If you could comment on that.
Sure. Yeah, if you didn't hear the question, you know, where are we going with primary care? I'm paraphrasing, but where are we going with primary care? 2 schools of thought. There's one school of thought that says that by 2020, which is only 6 years from now, we will have somewhere between 50 and 100,000 fewer doctors than we need. There's another school of thought that says we have more doctors than we need today. And that's because if we are, as a nation, if we are going to be seeing fewer and fewer patients seeking care because of prevention and wellness, that there may indeed not be a physician shortage. Personally, I think there will be. We're seeing it in our region. We're seeing it nationally. So I think there will be a primary care doctor shortage. But to your good question, many of those positions are not going to be filled by physicians, but they're going to be filled by physician, licensed independent practitioners, let's say, right? So some people may know them as physician extenders, nurse practitioners, physician's assistants, and so forth. Because what we're seeing is we can't recruit, as an industry, we can't recruit a lot of doctors today because there's not a big enough pipeline out there, especially who are interested in the area of primary care. 12% of doctors are in primary care today. And it's very hard when you're on call 7 days a week, 24 hours a day. Now you share a call, obviously, with a partner or 2 or 3 partners, but that's a very, very difficult thing to do. So I think we're going to see more with licensed independent practitioners, such as physician's assistants and nurse practitioners.
I think we have time for one more. Bob?
My question relates to following the money. We hear a lot of noise these days about where the money is going and where it isn't going. I'm interested in knowing, I think most of us in this room probably have a sense that we're going to be paying more for healthcare insurance in the years to come. Yet we hear the nation, and we hear that you say that you're significantly costs in your system. And yet we hear nationally that too great a percentage of money is being, of the too great a percentage of gross domestic product is being spent on healthcare. I just have difficulty sorting through the macro and the micro to figure out, is it going to cost less? Are we going to be paying more? Are we going to get, and I think we will get better quality, but the question is, where is the money flow here? Are we solving the nation's problem? Are we at our individual costs in this room, you think? Or does your reduction in costs make a significant contribution?
You know, Bob, I think what we're going to end up seeing is we will end up, as individuals, pay more for healthcare services than we've ever paid before. And I think that's going to have a chilling effect on people's willingness to seek care. And that's what I mean by that moral hazard that I opened my comments with. Now, you know, the problem with that is if $5 will keep someone out of a doctor's office, and they have a problem that should be addressed today, but put off 3, 4, 5, 6 months until it becomes acute and critical, can lead to significant deleterious consequences, as we all know. So we have to think hard about that. But how many people in this room work at an employer that have a high deductible health plan? Let me see a show of hands. My guess is that if we ask this question a year from now, everybody's hand will go up. And we're seeing it happening today. The most calls that we're getting now to our finance department are, if I were to come in to get a CT scan, how much is my copay, how much is my deductible, and how much is my total charge? I think those are the right questions to ask. But what should also be asked is, and how do you measure the quality of the service that's going to be provided? But I think what we're going to see is a whole different level of service offering too, because people may not need to go to the latest and greatest CT scan. They may be willing to pay less for an older technology, for example. Don't know, hard to tell. But I think as we take a look at Adam Smith, right, when we take a look at the laws of supply and demand and what's happening really in the world of healthcare, for the very first time, we are actually being asked to pay more for healthcare services than we've ever paid before. We're doing our best to keep our costs as low as we can. If I could just share a quick anecdote. We have about 25,000 people who we care for in a self-insured health plan. Our annual costs for healthcare are about $135 million a year, plus minus, in that range. We put a high deductible plan in place for our employees 3 years ago. For the first time in our history, since I've been there at least, we fell off of the Northeast Ohio top 100 places to work, which was a blow to us, right? But at the end of the day, in each of the 3 years since we put our high deductible health plan in place, we think we've improved quality, we've improved service, and our healthcare costs today, going into 2014, are the same that they were in 2010. So there is an answer, but the question is, at what cost does that answer come? In our case, we had 20% of our people when we started this had a primary care doctor. Now 75% of our employees have a primary care physician. It's one of the requirements to be in our plan, because we have coordination of care. So I don't know how many physicians here are primary care doctors, but instead of, you know, I overdid it this weekend playing tennis, my shoulder's sore, you know, why don't I go see an orthopedist, or why don't I get an MRI? Well, now you call your primary care doctor, and they give you the advice that you need, and maybe it's serious, maybe it's not. But we're going to see, I think, more and more of that happening in the year and in the years to come.
And then the ultimate question is, will that reduce the cost and the percentage of gross domestic product that the country devotes to healthcare that needs to come down?
So empirically, in 2010, 11, and 12, healthcare costs in each of those years went up by, I think, 3.9%, 4.1%, and 4.2%. The lowest rate of increase since the Medicare program was initiated. So I think the short answer to your question based on that is yes.
Now don't let Bob cross-examine.
I think you're leading the witness.
As a token of our appreciation, Tom, here is a bottle of Inigo wine from the Jesuit Vineyard in Australia. And
Perfect.
thank you so much for your
Thank you. It's great to be here. Thanks for having me.
And just a couple of announcements before we break. Please note on the back our next two speakers, Oliver Luck on May 14 and Father Bob Spitzer on October 27. Please note that October 27 date is a Monday. We're usually here on a Tuesday or a Wednesday or a Thursday, but that's the schedule for that event. We hope to see you then. I also had a couple questions about how do you join Loyola Club. It's real simple. All you do is ask. Doesn't cost anything, there are no requirements, there's no nothing. And at risk of getting in trouble with Maura McClendon, just send an email to admin@loyolaclub.com, and that way you will be on the invitation list. .org, pardon me, admin@loyolaclub.org. You'll also see a reservation website on the back of the program, so please hold on to that. And with that, I call on Dr. Peggy Finucane from John Carroll University for our closing prayer.
Today, as we reflect on bringing our values to all we do, let us join together and pray for all leaders. We pray for the leaders of our communities who face difficult decisions. We pray that they, like Tom Zenty, will have the courage to bring their values to their daily labors. We pray that they continue to be wise leaders, dedicated to service. We also pray for the future leaders that we are educating today. We pray that as these young people develop, their experiences prepare them to stand in solidarity with those least among us. We are called to provide opportunities that educate the whole person, such that they are not just exposed to ideas, but also have contact with the realities of the people in our world. We pray that our leaders of tomorrow will walk side by side with those who struggle most, struggle to find food, shelter, care and compassion, acceptance or employment, that they will visit those who are imprisoned or those who are facing illness or death. We pray that through their education they will be prepared to build and sustain a more just and humane world. We pray that they find that which transforms them, that which, in Father Pedro Arrupe's words, seizes their imagination and leads them forward. In closing, we pray with Father Arrupe's words. Nothing is more practical than finding God, than falling in love in a quite absolute and final way. What you are in love with, what seizes your imagination, will affect everything. It will decide what will get you out of bed in the morning, what you do with your evenings, how you spend your weekends, what you read, whom you know, what breaks your heart, and what amazes you with joy and gratitude. Fall in love, stay in love, and it will decide everything. Thank you.
Thank you, Peggy. That concludes our program. See you in May.